I want to start today with a scenario that feels almost too simple to be a real medical mystery.
Okay.
So picture yourself in a clinic. You're the doctor. A patient walks in, sits down, and just says, "Doc, my nose is blocked." That's it. I mean, it sounds like every cold you've ever had, doesn't it? But then you ask a few questions, and you realize something specific. The blockage, it's not on both sides. It is strictly, stubbornly on one side.
And that is the moment the entire room changes.
Really?
Absolutely. If a patient has a stuffy nose on both sides, you're thinking, okay, allergies, maybe a viral cold, a deviated septum.
The usual stuff.
The usual suspects, exactly. But unilateral, one-sided, it's a trigger word. It changes the game from take 2 of these and call me in the morning to we need to investigate this right now.
It's the difference between, say, a random noise in the attic and a broken window.
That's a perfect way to put it. A unilateral mass implies a specific localized thing. It's not a systemic reaction. It's a growth in a very specific space. And our job, looking at these notes today, is to figure out what that thing is.
Which brings us to our source material for this deep dive. We have a really dense set of notes here titled Differential Diagnosis for Unilateral Nasal Mass.
Right.
And it reads less like a textbook and more like a detective's case file.
Yeah.
There's a whole lineup of suspects ranging from the, merely annoying to the deadly.
It really is a lineup. You've got the benign imposters, the dangerous mimics, and then the true villains.
Yeah.
And you can't just guess. You have to use the patient's history, the physical exam, imaging. You rule them out one by one.
Okay, so let's start the interrogation. We're going to look at the benign suspects first. These are the ones that aren't trying to kill you, but they act a bit weird. The first one on the list is the antrochoanal polyp, the AC polyp. Now, I was reading how this thing grows, and it doesn't really make sense to me. Most things in the nose just kind of sit there. This one seems to migrate.
It does. It has a very distinct travel plan. It usually starts in the maxillary sinus. That's the one in your cheek.
Okay.
But it doesn't stay there. It grows backward out of the sinus and heads towards the nasopharynx. That space way, way back behind the nose.
But why backward? Why not just grow forward out of the nostril where there's plenty of room?
It's basically following the physics of your face. It's not choosing to. It's being pulled. First, you have gravity helping it along.
Right.
But the really fascinating driver is the airflow. Every single time you breathe in, you create a current that pulls backward.
Like a little vacuum?
Exactly like a vacuum. And on top of that, you have the mucociliary clearance system.
The little hairs?
The cilia, right. Microscopic hairs that act like a conveyor belt for mucus. And in that part of the sinus, that conveyor belt runs posteriorly. So this polyp is literally riding the wave of your breath and your own biology right to the back of your throat.
That is just bizarrely cool. It's surfing the cilia.
Pretty much, yeah.
Now, there's a note here about bleeding. I feel like if I had a weird growth in my nose, I'd expect it to bleed. But the text says something else.
Yeah, that's a huge misconception. Generally, benign polyps do not bleed. They're just these pale, waterlogged bags of tissue. If you see a mass that's bleeding heavily, your mind should immediately worry it's something else.
There's an exception.
There is. One exception mentioned in the notes called an angiomatous polyp.
Angiomatous.
Yeah.
Sounds like blood vessels.
It is. So here's what happens. Sometimes that polyp gets stuck somewhere where it's constantly getting battered by the air you breathe.
Okay.
To protect itself, the polyp undergoes what's called squamous metaplasia. It basically toughens up. It grows a thicker skin and new blood vessels.
So it's like it's growing its own armor.
In a way, yes. And because of all those new blood vessels, it can bleed. But that's the exception, not the rule.
Got it. Okay, let's move to the next suspect, the imposter, the hypertrophied inferior turbinate. Now, the turbinates are those shelf-like bones inside the nose, right? The ones that warm the air.
Correct. Everyone has them. But sometimes they get swollen hypertrophied. And to an untrained eye, or even just a tired doctor, a swollen turbinate can look a whole lot like a tumor.
It's pink, it's firm.
It's taking up space. It checks a lot of the boxes.
So how do you tell the difference without, cutting into it? Is there a trick?
There is, and it's incredibly simple. You use a vasoconstrictor test.
Right.
You just put a few drops of a decongestant in the nose. This chemical shrinks normal blood vessels. If the mass just shrinks away and opens up the airway,
It's just a turbinate.
it's just a turbinate.
And if it doesn't shrink,
Well, tumors don't care about nose drops. If it stays the same size, you've got a problem. Simple, elegant, I love it. Okay, the infectious mimics. So we've got bugs pretending to be tumors. The notes highlight something called rhinosporidiosis.
a mouthful.
It is, and it seems to have very specific criteria for diagnosis.
Right, it's a fungal infection, and have a classic look. But what's really helpful here are the negative points in the source. You can rule it out pretty fast if the patient doesn't fit the profile.
Notes list. Not from a coastal area, no cheek swelling, and not studded with white fungal spores.
That last one is the huge visual giveaway. Rhinosporidiosis looks like a strawberry. It's this red mass studded with little white dots. Those are the spores. If you don't see the strawberry and the patient's never been near the coast, you can probably cross this one off your list.
Then there's tuberculosis. I always think of TB in the lungs, but it can set up shop in the nose too. The text mentions a really specific visual sign. Apple jelly nodules. It's a classic description, still holds up. If you look at the lesion, you might see these reddish, firm nodules that look a bit like, well, semi-transparent jelly. Or you might see an ulcer with undermined edges.
Undermined edges. What does that actually look like?
Imagine digging a hole in the sand, but you dig out the sides underneath the rim so the top lip sort of hangs over the empty space.
I see.
That's an undermined edge. If you see that in a nasal ulcer, you need to test for TB immediately.
Okay, so we've cleared the benign stuff and the infections. And now the music changes a bit. We're entering the dangerous middle ground. And there's one suspect here that really freaked me out when I was reading the notes. The inverted papilloma.
This is the villain that smiles at you. We call it the wolf in sheep's clothing.
Why?
Wait.
Because it looks innocent.
It looks totally benign. The notes describe it as a polypoidal, grayish pink mass. It's firm, it doesn't look like it's rotting, it's not scary to look at all.
Well, the stats, I had to read this twice. The source says it has a 10% chance of turning into cancer on its own.
Right.
But then it says there's a 56% chance of a coexisting malignancy.
That is the number that matters.
56%. So you're telling me that if I have this benign looking lump, there's a better than a coin flip chance that there is actual cancer hiding inside it right now.
That's exactly the reality. It's not just that it might become cancer, it's that it very well might be a mask for a cancer that's already there. The carcinoma could be nestled deep inside the folds of the papilloma.
So how do you find it if you just snip the top off? you could miss the cancer, couldn't you?
And that would be a catastrophic miss, a disaster. If you treat it like a benign polyp, the cancer just spreads. That's why the notes really emphasize the biopsy rule. You cannot just take a surface snip.
You need more.
You need a deeper biopsy, and you need multiple bits. You have to search the whole house, not just glance in the hallway. You have to map that entire lesion to make sure you're not missing that coexisting killer.
Which brings us to the actual killers, the malignancies. And this section of the deep dive gave me pause, because the source material links these cancers to specific jobs. It's not just bad luck, it's what do you do for a living?
This is one of the most significant environmental links in medicine. The air you breathe at work can literally rewrite the cellular structure of your sinuses.
The big one here is wood dust. But the notes are so specific, they distinguish between hardwood and softwood. Why does the type of tree matter?
It matters for the type of cancer you get. The data shows that exposure to hardwood dust predisposes you specifically to adenocarcinoma, but exposure to softwood dust, that leads to squamous cell carcinoma, or SCC.
That is just wild. But how does sawdust actually cause cancer? Is it just constant irritation?
It's more mechanical than that. The notes explain that there are biologically active compounds in the wood dust that impair mucociliary clearance.
That conveyor belt we talked about earlier.
Right. The wood dust effectively paralyzes the cleaning crew. So instead of being swept away, those carcinogens just sit there. They linger on that delicate lining of the nose, festering for years, until eventually the cells mutate.
And it's not just woodworkers. The list here has leather manufacturers, chrome pigment workers, and this one, watch dial painters.
That is a tragic piece of history.
The notes mention thorotrest.
Thorium dioxide. It was used in luminous paint, so watch dials would glow in the dark. It's radioactive. And the workers, often they were young women, they would sometimes use their lips to point the brushes to get a fine tip. They were ingesting and inhaling alpha emitters. And years later, they developed these terrible malignancies. It's a very stark reminder that the nose is our first line of defense against the environment, and often it's the first victim.
So let's profile these killers. We know the cause, now let's look at the tumors themselves. The most common one is squamous cell carcinoma, SCC.
Right, and it usually starts on the lateral wall, the side wall of the nose, but the notes give a very specific warning about location. If you find the tumor on the nasal septum, the middle wall, or the columella,
the skin between your nostrils.
Yeah, if it's there, the prognosis plummets.
Why is the middle worse than the side?
Drainage. The lymph nodes, the body's drainage system, are set up so the side wall drains to the neck nodes on that same side. But the center, the septum, it has access to both sides of the neck.
Oh, wow. So it can send cancer cells to the left and the right at the same time.
Bilateral metastasis, it just doubles the battlefield you have to fight on.
Then there's adenoid cystic carcinoma. The notes mention a sort of superpower for this one called perineural invasion. What is that?
It means it doesn't just grow like a ball of tissue. It uses your nerves as a highway. It wraps around the nerve sheath and just travels along it, often spreading far, far away from the main tumor site.
That sounds like a nightmare for a surgeon. You think you've cut it all out, but it's already halfway down the nerve.
Exactly. It makes getting clear margins incredibly difficult.
What about melanoma? I'm assuming that's easy to spot because it's black, right?
You would think so, but the nose can play tricks on us. The notes point out that mucosal melanoma can be amelanotic.
Meaning?
What?
Invisible.
Meaning it has no pigment, it's not black, it might just look pink or fleshy. And to make it worse, it often has satellite lesions.
Little outposts.
Yes, tiny little spots of cancer popping up around the main mass. If you don't look really closely, you miss the satellites and the cancer comes right back.
And lastly, the olfactory neuroblastoma.
That's a rare one. It arises from the smell receptors themselves, the olfactory neuroepithelium, right at the very top of the nose, dangerously close to the brain. It even has its own special staging system, Kuttish staging.
Speaking of close to the brain, let's talk about the escape routes, the anatomy of escape. How do these tumors get out of the nose and into the rest of the head?
Think of the nasal cavity like a room. The walls are bone, but the tumor is constantly pushing on those walls, looking for a weak spot. The notes list the defenders, the barriers that hold the line for a while. That's the periosteum, which is the skin of the bone, and the dura, the thick covering of the brain.
So those are the reinforced doors. Where are the weak spots? Where does it break through?
The path of least resistance. The notes identify the canine fossa, that's the front face of your cheekbone, and the orbital floor, the really thin bone right under your eye.
And this leads to some horrifying physical signs. The text describes how you can tell where the tumor has gone just by looking at the patient's face, like if they have loose teeth.
Well, think about it. If the teeth are loose, the bone holding them in is gone. It means the tumor has eaten through the floor of the sinus into the jaw.
What about trismus? That's lockjaw, isn't it?
Yes. If the patient can't open their mouth properly, it means the tumor has broken out the back of the sinus and has invaded the pterygoid muscles, the muscles you use to chew.
And epiphora, watery eyes.
That tells you the tumor is blocking the drain pipe, the nasolacrimal duct. If it's blocked, your tears can't drain, so they just spill over your cheek.
This last one is the most chilling to me. Numbness. The notes break it down by nerve.
It's like a mapping exercise. If the patient's forehead is numb, the tumor has gone up and hit the V1 nerve. If their cheek is numb, it's gone forward and hit the infraorbital nerve, V2. The patient doesn't feel pain, they just feel nothing. And that nothing is a sign of very deep invasion.
So we've done the physical exam, we suspect that nerves are involved, now we need pictures. The diagnostic toolkit lists CT and MRI. Do we really need both?
You almost always need both because they tell you two totally different parts of the story. The CT scan is like the architect's blueprint. It looks at bone. You want to see if those walls we talked about are broken.
There's a specific detail in the CT section about the eye, the fat plane.
This is critical. Behind your eyeball, there's a cushion of fat that protects the optic nerve. On a CT scan, fat shows up as a nice dark line. It's very distinct. If I look at a scan and that dark line is gone,
The barrier's been breached.
it means the tumor is touching the optic nerve. And that changes the surgery completely because now the eye itself is at risk.
So if CT is for bone and fat, why do we need the MRI?
Because of what I call the secretions problem.
The secretions problem.
Yeah, imagine a blocked nose. What happens behind the blockage? Mucus builds up, retains secretions.
Right.
On a CT scan, a tumor looks gray. A pile of snot also looks gray. You can't tell where the cancer ends and the fluid begins.
That seems like a pretty big blind spot.
It is. You might think a tumor is massive, but actually half of it is just trapped fluid. The MRI has the superpower to tell the difference. It lights up differently for fluid versus solid tissue. That tells the surgeon exactly what they need to cut. And MRI is the absolute best way to see if the tumor has gone up into the brain.
We're sort of reaching the end of the case file here. We've gone from a simple blocked nose to wood dust to nerve invasion to these advanced scans. We have to talk about the outcome. What's the reality for a patient facing this?
I won't sugarcoat it. The treatment for these malignancies it's heavy. It usually involves a radical maxillectomy.
Which means removing the maxilla,
It's back?
the upper jaw,
Yes. It's a major, major surgery. And if that fat plane behind the eye is gone, like we discussed, it might require orbital exenteration.
Removing the eye.
Correct. Followed by radiation. It is a life-altering treatment path.
It really drives home why that first moment, the patient walking in with a unilateral blockage, is just so high stakes.
Oh.
If you catch it while it's still small, before it hits the fat plane or the nerves.
You save the eye, you save the jaw, you save the life. The difference between a cure and a tragedy is often just how seriously we take that one simple word, unilateral.
So what's the big takeaway for us today? Besides the fact that I'm now going to be very suspicious of any one-sided stuffy nose.
I think it's about connection. We tend to think of our bodies as separate from our work, from our environment, but this deep dive just proves that what we touch, what we breathe, whether it's wood dust or chemicals, it leaves a mark.
That's what I'm left thinking about. We talked about woodworkers and watch painters, and it's easy to file that away as sort of old-fashioned industrial problems. But if something as simple as wood dust can shut down your nasal cleaning system and rewrite your DNA, what are we breathing in today?
That is the question. What are the softwoods of the modern era that we just won't identify for another 20 years?
Something to think about. Thank you for helping us crack the case of the unilateral mass.
My pleasure.
And to everyone listening, keep your airways clear, stay curious, and we'll catch you in the next deep dive.